I have a difficult task because this is an area which you all know and probably practice every day. So I've got it, and following me is Sean Bagshaw, who is going to tell you about timing. So it's kind of a mishmash of what I can present without going on his turf. These are my disclosures. And what I'm going to start with is walk you through some of the thought processes which go through the mind of a nephrologist or intensive care physician in terms of looking at dialysis. So the first question, what are the indications for RRT? And here is a list. This is drawn from Ronaldo's paper from several years ago. And as you can see here, this list has not changed, and it's in textbooks, it's in multiple publications itself. And it was actually taken up by the KDIGO recommendations, and you can see in this slide, most of the recommendations stem on saying is if there's an emergent treatment, utilize this list to tell you what to do and when to start treatment. Well, that being said, I'd like to point out to you that these indications actually represent an end stage of kidney dysfunction where you have complications ensuing, and that's when we recommend starting dialysis. So please keep that framework of reference in mind as we walk through this. So the second question here is essentially, do we use these indications in current practice? Here's a data set from Sean's, just a multi-center observational study in Canada. And you can see in this group of patients here, about 234 of these patients, they all had the indications as shown in the same manner. Most of these patients were treated at a much later stage, and you can see the large significant number of them were anuric at the time of their start, and also they were significantly fluid overloaded overall. This is the same indications which we used for Ronaldo's Renal study in terms of including patients coming into the study design, and this is the same for the ATN study, which Paul did. More recently, when we looked at this from 11 ICs from Canada, again from 2009 and 2010, where they actually asked clinicians to record what their clinical indications were, and also the variables in terms of the timing of renal replacement therapy indication. They found that out of the 119 patients they had, at the time the creatinine level was fairly high, and the SOFA scores were fairly high. So suggesting again, to a large extent, these patients were being dialyzed at a much later stage. And again, if you look at the time course hospital admission all the way to initiation of RRT, most of these patients had transitioned from a stage 1 AKI, if you just use that as a parameter, all the way into stage 3 AKI by the time they started dialysis. These trends also represent another element here. So when you ask the clinicians in this study in terms of what was the relevant variable that they were dialyzing these patients at, what you recognize is that the vast majority of them were based upon oliguria and all the recognition there. But when they correlated this to the actual recommendations which are traditional, you can see that most of them started the dialysis at a little earlier time point than actually meeting those recommendations as such. So the overall, most of these patients had more than one indication by the time they started dialysis. Now, if this is true, we also did a study which is just being published in CJASN looking at an international registry from multiple countries around the world. And in this, from 2000 to 2012, we had about 1,300 patients who were included. And here, when we asked the question in terms of what were the indications and criteria for starting dialysis, you can see whether it was the developed world or emerging countries, they were relatively the same. So in answer to that second question is, are we using them in practice? The answer is probably yes. And in our analysis from this international registries, you can see that to a large extent, about 23% required renal replacement therapy, and patients from developed countries were less often treated with dialysis, even though dialysis is much more available in the developed world as such. Well, that leads to the third question then. Is there evidence that these indications are valid? Because if we've been following these for so many years, there must be some truth to them, and I've got to find that evidence. Because that's a key aspect in terms of otherwise, why are we continuing to do the same thing? Well, there's two ways to assess that evidence. One would be if we can show that if you meet those indications and if you don't do something, something bad will happen. That would be one approach to answering that question if they're valid or not. Well, there is a study which has done this, and the MIMIC database is a large ICU database from Boston, where we've got about 18,000 patients who were enrolled, and the data is available for anybody to actually access if you had the right permissions. So this group looked at the MIMIC database and analyzed it, and as you can see here is they had about 10,000 patients who developed AKI using the AKI criteria, and the stages are shown there on the left side. And they asked the question is, okay, of the people who require dialysis, and if you took the patients with AKI, and you assessed the risk for mortality for each stage, and I'll just walk you through this. On the left side in Model 1, they looked at the relative risk for mortality for each stage, and you can see there's incremental. If you add the indication of hyperkalemia in this, you can see that this mortality risk starts getting attenuated. So part of this risk was because of hyperkalemia. Part of the risk was of hyperkalemia, metabolic acidosis, and then part with metabolic acid and cumulative fluid balance. So if you take the three major indications overall, you can demonstrate that you do attenuate the risk attributed to the AKI itself in that setting. And in the patients who were treated with RRT, the main burden of the excess mortality was attended by metabolic acidosis and cumulative fluid balance itself. And when you looked at it with respect to those patients who had or did not have metabolic acidosis, and this is the risk of mortality, you can see it evident across all the board. If you take this one step further and put this of the patients who require RRT, you can say, yes, certainly those patients who have these indications are at much higher risk of dying. So there does seem to be some suggestion that these indications have value with respect to predicting an adverse outcome. The question is this the right approach for us to be taking? Because as I've already suggested to you, this is sort of an end result of a complications of a failing kidney where we say we should be actually dialyzing these patients. So let's ask the next question is, what would be affecting these parameters that we rely our clinical judgment on so much? Well, take a look at this. In terms of the blood urea nitrogen as being a level there, you can see that blood urea nitrogen is affected by a variety of different factors. And again, depending upon what threshold you use, your time to get to that threshold is highly variable across. But more importantly, how long you stay in that elevated threshold also varies. So that becomes a key issue for us to keep in mind, is that's not only the time of a particular level you want to get to, but also the duration that you've been exposed to that. And the same way with respect to creatinine, it can be underappreciated in the setting of fluid overload, as is now been well recognized itself. So if the components are themselves subject to variation, depending upon the underlying disease process, then we need to be careful in terms of applying the same indications across to every single patient we see, because that may become a problematic aspect of how we manage these patients. So if we are so endeared to using indication-based approaches, looking at a list, what is the problem with respect to part of it? The second problem is that it delays initiation. So this is a study from Finland where they looked at all ICU patients and asked the question is, how many patients got dialysis and did not get dialysis? And they stratified this patient population in those patients who got an early renal replacement therapy based simply upon the time to when they started, to those patients who had classic urgent indications versus classic delayed indications itself. And what you recognize here is that when you look at the outcomes from the classic urgent and classic delayed, you can see that there are more patients who have more fluid overload with pulmonary edema in those patients who have classic delayed indications itself. So that tends to represent, and more importantly, when you put this in terms of a logistic regression for 90-day mortality, you can see quite clearly here is classic RRT versus delayed versus urgent has a significant increment in terms of the risk for overall mortality. Well, what does that tend to suggest then? It suggests that if you wait long enough for an indication to appear, you are sacrificing time. And that sacrificing of time becomes a key aspect of how we may need to think about this. So the third element of an indication-based approach is it does not consider comorbidities and the settings in which it is done. So Marlies Osterman, who will be speaking again, I think later on today or tomorrow, has shown this in a nice, elegant study looking at multiple ICU database and looked at patients who met AKI stage 3 at the time they got dialysis itself, and then looked at patients who survived versus did not survive in this setting. And what you can see here is, here's the ICU mortality depending upon what the serum creatinine level was, what the serum pH was, and serum urea level was, the same criteria we use for indications itself. But more importantly, also taking into place as to what the severity of organ dysfunction was at the time of RRT and its contribution to the ultimate outcome. And you can see the higher the number of organ failures, the more likely the patient was to have an adverse outcome. So the key question then becomes is that if we start looking at these indication-based approaches, we are not necessarily taking the entire picture in mind in terms of how we manage these patients, and that becomes a key thing for us to be thinking. The last aspect of this is that the non-traditional indications, if you start dialysis earlier, or if you decide to do not based upon that I've got to wait till the pH is less than 7.15, or I have to wait till the urea is a particular level, tends to suggest that you have a better outcome. So this is a study from the VA looking at a cohort of about 2,700 patients here, and they stratified these patients in terms of initiating dialysis based upon the stage of AKI, but then they had a group of patients who did not meet any AKI criteria, and they still got dialyzed. And when you look at those as a reference point as group 4 here, you can see that the ones who required dialysis without any stage, no creatinine increase before dialysis, actually had the best outcomes, and these were the patients who had essentially the worst outcomes as you went down to a particular stage. In another study which has been just published recently, this was a prospective cohort study of medical and surgical ICU patients. Again, patients who were referred, these were the KIN stages 3, and those patients who were dialyzed with starting IRT without the evidence of an AKI stage 3, you again found that the outcomes were very different, particularly in those patients who had non-traditional indications for dialysis. So does that mean that we are actually skirting on very thin ice in this setting when we say we've got indication-based approaches, that we should start dialysis only when a certain level is met? We actually start to be opening up our thought process a little differently and asking the question is that, for example, here the traditional indications are absent. You can see those in terms of ICU mortality and hospital mortality are significantly lower when these traditional indications were absent. Now, whether this is only a question of the time or how you do it, it's more a question of us reflecting on how we appreciate each patient population and how we tailor our therapy to meet the needs of each patient itself. So the first aspect of this is how would we react? If I said to you, we must do things differently, well, what thought process would you want to go through? The first thought process here is we've got to understand the process which goes through our minds when we make a decision of whether or not to offer dialysis to an individual patient. And these processes stem into a variety of different components. You can see here they're based upon both patient characteristics in terms of the severity of illness and the trajectory based upon these parameters. It is also based upon us always weighing in balance whether or not dialysis would be unnecessary, because you want to avoid the potential complications of placing a vascular access and subjecting somebody to dialysis itself. In addition to that, we are influenced significantly with the risk associated with the procedure and also whether or not the patient will actually benefit from it in terms of utility. All of these elements then coupled with the process of care decision, the logistics, make a complex set of decisions which make it very easy to then basically say, okay, well, let's look at the list. And if the list says yes, then we must do it. Outside of that, it takes away the cognitive thinking and the ability which is necessary to make a complex decision like this. So in essence, we must weigh in balance on an ongoing basis as to when and when not to offer dialysis for a particular individual. So given this overall arena, is there a simpler way? Is there a way that we could approach this in a manner? And I know that there are multiple studies which are ongoing, and Sean will talk about a little this. I'm just going to share with you some of the things that we've been working on and utilize, at least I utilize in my own practice on a daily basis. I realize that, first of all, one of the key concepts we have to keep in mind here is that patients will span the spectrum of illness and they will change. This is dynamic. An indication on one day is likely to change on the next day. So keeping that first perspective in mind is absolutely crucial as we make these thought processes there. And that's allowed me to think about it in a slightly different way and say, okay, can I, at any given point in time, classify patients in terms of what is the demand which is being placed upon the kidney and versus the capacity of that kidney itself? And if you can do that, you can build people into these 4 groups overall, where depending upon the mismatch of the demand and capacity, you're able to understand what is the burden which is being placed on the kidney itself. For example, you could have a patient who has got a phenobarbital poisoning. His kidney is normal, but requires dialysis just to get rid of the phenobarbital. That's a setting where you have a high demand capacity. Normally, you want to augment it. On the other end of the spectrum is somebody who has a malnutrition and CKD, who is able to manage his current level with no major problems itself. And in between, you've got the major in-between categories, which we see in daily life itself. So given these 4 scenarios, you could then attribute and make a change according to what you would want to do in terms of reducing the demand or increasing the capacity, depending upon the situation which is there. Now, how does this apply into clinical practice? To do that, I will take the last few minutes to just share with you a patient itself in terms of how it used it. So this was a 73-year-old man who had a partial colectomy for diverticular disease. In the post-operative period, he had hemodynamic instability, required vasopressors. His past medical history is outlined here. His baseline creatinine was 1.3 milligrams. On the third post-operative day, he had his hemodynamics had improved, and his dobutamine was still kept there, and he developed a positive fluid balance the 4th post-operative day, and nephrology was asked to consult. These are his parameters at the time of the consultation. This is what his X-ray looks like. He has a BNP about 1,500 there, and his weight is 90 kilograms. You can see this is his 40% FiO2 and his oxygenation occurring. On the 4th day, when the nephrology was consulted, these were his values here. His urine microscopy showed granular CAS. His white count was still high. His lactate was 2.3. And at this point, I'd just ask you to contemplate and think if any of you would offer dialysis to this patient. Would you please raise your hand if you would? Nobody. Okay. Let's take it one step further. This favors no RRT. This patient has not reached the criteria for AKI. His urine biochemistry favors a reversible AKI. You could just increase the diuretic dose because he's been volume overloaded. Okay, that's exactly what was in. But in terms of favoring initiation, you could think there's a lack of increase in BUN and creatinine be associated with the positive fluid balance that he's had. And his increased BNP is associated with heart failure, increased fluid overload, and he's got some metabolic acidosis, which is brewing. So you are always weighing in balance those 2 things. Well, 24 hours later, this is what he does. His heart rate is increased a little bit. His blood pressure is lower. He is now on a higher oxygenation, and his SVO2 has decreased. His chest X-ray is starting to show a little more fluid on board. His urine output after the Lasix, which is now at 360 milligrams, has actually not reduced, and he's in more positive fluid balance at this point. And his lab studies here after 24 hours now show a potassium which is elevated. His creatinine is going up. His white count has come down. His lactate is also about the same as before. So at this stage, would you consider? We have a few hands which have shown up which say that they would consider, okay? If you look at this, here's the consultation, the changes which have occurred overall, his BUN and creatinine, as I've just pointed out to you. And again here, the same favors for no RRT has not met the AKI criteria yet, but volume overload and slow increments are over there. His worsening metabolic acids, and the more important thing is unlikely to improve renal function in time to meet this in continued demand, fluid demand. So this gets into the situation where evaluating a particular demand in the current capacity of that kidney becomes an opportunity for us to be able to do this. So I'll leave you with this last sort of concept here is we do need to develop better criteria. I think that simply looking at indications which are sort of terminal in my mind to basically wait till you start dialysis is probably not appropriate for the vast majority of patients. I think those indications just stem largely from the end-stage renal disease world situation where you have no opportunity to make any difference. I think that how we go about doing and defining what is timely for any particular individual is obviously a key question. But I think relying simply on a list is not probably appropriate. I think it's much more important to have a dynamic assessment and an opportunity to continue to evaluate these patients before we make a decision for dialysis. And again, I have Claudia's permission to welcome you to San Diego in February next year.